and invitation for this seminar, for this meeting. I'm very delighted. I think that I've been in Portugal in other type of meeting because of my research, but this may be the first time ever I speak of open dialogue in Portugal. It's very rare because it seems that in most of the other countries in the world there is a lot of interest of this way of working. Of course, not all, but it's a kind of a idea that has spread during the last years a lot. And of course, we are very enthusiastic and very positive that the experiences that we have had in developing a new kind of more human and family-centered services in Finnish Lapland really has caught a lot of interest. And of course, because we know that it's a different and it's a different system, and because of the lot of research, we also know that the outcome seems to become much more different compared to what we are used to think in psychiatry. And that's why I, of course, want that those experiences should be available for all the ideas, that all the practices that has been developed. I will start and say some words of a very fresh study that was published 1 month ago. And it was a study in Western Lapland in Finland. Western Lapland is a very small province in Finland. It's one of the 21 special health districts who has a total responsibility of the entire healthcare in their province. It's the smallest one, but it's the idea that we had and they have the total responsibility of everything. We have had a special interest of doing research of psychotic patients, and we had 3 inclusion periods of first-time psychotic patients who came into the treatment in this province. First of them being part of a national study between 92 to 93. And the second one was that we followed up 94 to 97. And then because of very interesting outcomes, we replicated the same design of the study 10 years after 2003 and 2005. And then now we have combined all these studies of these 3 inclusion periods of first-time psychotic patients. And altogether I had information of 108 first-time psychotic patients who came into the treatment in Western Lapland during between 92 to 2005, most of them at the 90s. And then we made a comparison how these are different compared to the rest of Finland. The TRU refers to treatment as usual. With all the patients who came in the treatment because of psychosis in Finland, 95-96, there were 1,736 patients. And it's quite surprising to see that there's a lot of differences still seen 19 years after when the original treatment happened. Those people in the traditional treatment, the mortality rate is much higher. Significantly higher, and they were on hospital much more. Almost all of them were more than 1 month in the hospital compared to the 18% of those who were in Finland. So all the hospitalization has been summed up here during the 90 years period of time. Half of those patients still have contact into psychiatric care in the rest of Finland compared to 28% of the people who came into the treatment because of psychosis in this open dialogue system. More than 80% are on neuroleptics compared to 36%, and perhaps this is the most shocking difference, so that people living on a disability allowance retired, not because of their age, because of their problems in the ability to work, it's 60% compared to 33%. This is very exceptional because in science, in long-term follow-ups, we are said that it's impossible to see the long-term outcomes of intervention after 5 years. while looking this, I'm a bit shocked myself that how come it can be possible that something that happened in the treatment with these people 20 years after are affecting a lot of their use of services 20 years after. This is not a control study of the treatment because we do not have any control of what has happened for them. If they, for instance, have had a new psychotic episode, half of them have moved to other part in Finland and they are part of the traditional system. Doctors prescribe medication if needed and so on. But still, something that happened in their treatment 20 years after in the first big crisis in their life is visible in the way that they suffer life and they need for services and it's quite amazing for me to think that there is something very, very new idea about it. One example of this very new idea, 4 months ago I got a letter from Jordi Marfa. Jordi is a psychiatrist with a very long experience working nearby in Barcelona. And we had a seminar 2016 in Madrid. And in this seminar, it seems that we had a discussion in a dinner table, and he had been asking that how to apply these open dialogue ideas into the practice. And it seems in his letter that I don't recall exactly our conversation that I have said that you need to have a team and then just go. And as a surprise to me, he wrote me, so we did it. This is very surprising to me again because I'm used to think that open dialogue idea is very complicated to put into practice. But Jordi said, no, we decided to do it and we did it. And then he writes that about an example that in his clinic what they have done, it's really a kind of open dialogue practice. They have created a team with him, social worker, nurse, and he describes a case of young woman suffer from first-time psychosis. They have had 20 meetings with the patient, with her family, and also with some friends. Having this openness to include social network is a very relevant part. And then he writes, the results are absolutely shocking. A doctor who has been working 45 years in the field, still using this kind of words, it's quite interesting and giving a reason to think that there is really something new in the dialogical practice. And the shocking outcomes are that they are not used to stop medication. In her case, the medication was stopped. She found job in 3 months and had a driving license and now has started to study in the university. I hear this kind of comments from people in many places. For instance, in Italy, we have had a very large project in open dialogue in 8 provinces, in which they had a training for 9 months and educated their staff, and people with a very high experience and very long experience in psychiatry. They are even swearing and saying that I couldn't believe that this is working. I don't repeat these swearing words now because I would be red on my face, but still, a lot of kind of surprising phenomenon can come out. And my point here is not to say that this is some new miracle method that has been generated in a dialogical way. Actually, I think that it's a bit the opposite, because when we speak of dialogue, we actually speak of in a new way compared to how we were used to think about some basic elements of human life that were disacknowledged for a long time in our understanding of human life. For me, the most important author in understanding the dialogical quality of human life and the power of dialogue is Russian philosopher Mikhail Bakhtin. And in this citation, Mikhail Bakhtin described this very beautifully. It's actually a kind of endnote in a book that he wrote that is called Problems of Dostoevsky's Poetics. He wrote this book 2 times, and in the second version that he wrote, 1963, he had this kind of endnote by concluding that actually life, its very nature is dialogic. To live means to participate in dialogue, to ask questions, to hear, to respond, to agree, and so forth. And then a sentence that I love. In this dialogue, a person participates wholly and throughout his whole life, with his eyes, with his lips, hands, soul, spirituality, with his whole body and deeds. And what Bhaktin says here is two extremely important things. He says that we participate in dialogue throughout our entire life, from the very first inhaling that we have in life. It's a very different point of view of human life that we were thinking 20 years ago, when we thought that human beings are psychologically empty and they step by step they start to become humans. But this is very different idea that has been verified a lot in the studies of intersubjectivity. Now we know that actually humans have an innate, let's say, biological capacity to be in dialogue from the very first inhaling in our lives. We are not a recipient of something, but we are actively creating our life by generating responses to another, and in those responses we become humans. And this responsive interaction is the idea of life. And all this, in my mind, puts ourselves in a very different position also than we are used to think, for instance, psychological or psychiatric symptoms and treatment of those. And of course, how profoundly wrong it is to focus on symptoms in taking care of the problems, and how it should be done in a totally different way, generating a dialogical context in which people become heard, as the small babies has to become heard in the very beginning. And for me this is amazing. It's a very simple, because actually what happens in life, there is two prerequisites for life. When I come to world, I need to learn to breathe. If I don't breathe, I will die. And at the same time, as important, when I come to world, I need to learn to be in dialogue, and if I'm not in dialogue, I'll die. So simple is life. And of course, this simplicity is very important for us working in the most severe mental health problems, because this is what we need and nothing else. And we are so occupied of everything else in our work, in our discipline. We think that we need the methods and interventions and techniques to take care of the specific form of the problems, as of course we sometimes do. But much more basic idea is, how do we come in a relationships in which people become recognized, respected and heard, and if that happens, they have access to their own resources. Of course, we know that unfortunately in psychiatry, this is the thing that people repeatedly say. I was not respected, I was not heard. They didn't have any interest of mine. The doctor only had interest in his interviews, how mad I am, and nothing else. And this, of course, is the very wrong idea of human life, in which we do not have access to use the resources. And secondly, by the way, this idea of dialogue for me means that when people ask that what are the indications for open dialogues, or what are the indications and contraindications for having dialogues, for me these questions do not exist. It's the same as asking what is the indication of breathing. I want to live. And that's why everyone needs dialogue. The form of dialogue is, of course, that we can decide and find out what is the best way. Lately, I very much like to. I also have a research project about the embodiment in dialogues. How do we respond in our bodies? That is the second part of Mihail Bachtin's idea, that we participate. This speaking part is only very minor part of communication. And that's actually, it's not communication, because we do the dialogue that in everything that we do. Of course, in our embodied corporeal presentation, how do we look, what happens in our skin and our gestures, our movement, but also much more in doing. I will not focus here, but there is a big change that has happened in psychiatry during the last 8 years, and it was opened by this Nancy Andreasen research about showing that medication made harmful effects to the brains. For instance, only showing, for instance, this citation that Robin Murray published 1.5 years ago when he said about the errors that I made, now saying that now we need to start to think that there may be happening some structural changes in the brain of schizophrenia patients, but those structural changes are caused by the treatment, not by the illness. And some very same type of ideas about depression and how are the differences in the depressive brain. For me, open dialogue is not for psychosis, but we have done most research of psychotic problems. And I also think that thinking a bit of psychosis is very important for us because it's a criteria, how do we understand human life? And that's why I've taken some ideas, what are the guiding hypotheses for me in understanding, also giving a reason to understand why these outcomes are so different in open dialogue compared to the way that we are used to things. And for me, psychosis do not exist. There is not a category that the people who have psychosis, they would be categorically different compared to people who do not have psychosis. There is a lot of attempts of this, but no research have shown that there is this category. It's some form of behavior that is possible for all of us if we are in a stressful situation. Actually, the textbooks that we read of psychosis, they are said that the behavior, reasoning, thinking of psychotic patients, they are signs of the illness. But actually for me, they are not signs of illness, they are signs of the survival strategy for the one who has these very extreme experiences. If I'm alone in a room and all of a sudden I start to hear voices, probably I'm scared to death. What in the hell is happening here? I need to have a survival strategy how to deal with this issue. And what happens here is that mostly people, I start to isolate them from human relationships. And this, for me, the isolation is the most dangerous things, because in isolation we start to create very odd forms of behavior to survive the situation that we are dealing. So this survival strategy, this odd behavior to survive, that's the one we deal in when we meet with people who have had psychotic problems. Thinking of long-term problems, my clinical work, I've been working perhaps mostly with people who have a very long time being psychotic in their lives. They are said that it's the sign of deepness of the psychopathology. For me, they are a sign of failure in treatment. And the failure in treatment comes out of at least two reasons. One of the reasons is that our system of care is organized in the way that there is not access immediately into the treatment when you are in a crisis. And we know in many studies that people may be psychotic between 1 to 3 years before they come. They have a lot of time to isolate themselves and generate very odd forms of behavior with their odd experiences that they are feeling. And of course the optimal care would be the one who is there immediately, so that we become a part of the survival strategy in their life, having curiosity of their way of seeing and reasoning. The second part of the failure in treatment comes out of the wrong understanding of human life. And for me, the wrong understanding of human life is the one to think that we could reduce mental health functioning in some part of human brain, or we could reduce mental health problems into some structural changes in human brain. Of course, human brains is very important. It's very important to have a research, but human brain is also a part of the interactional and embodied social interaction, all the time ongoing stream, as William James already 120 years ago said. Life is a stream, consciousness is a stream in which we participate instead of having some fixed qualities into which we could reduce the work. And if we have this kind of understanding, it leads into the conclusions that people need to be medicated because they have some neurotoxic process. And this is totally nonsense. And this is very harmful because it disacknowledges to see ourselves as a full human being and with all the things and emotions that everyone else. Nowadays I've started to think about psychosis, psychotic problems, that they are emotions, they are affects, as any other type of affects. Anxiety, depression, being panic, and so on. Something that we all need if we are a stressful enough situation. Many people say that if there are many stress factors at the same time, that's the point in which I find this solution in my mind to create hallucinations to survive this something worse that may be happening. I don't have it is only a kind of rehearsal in my mind to think that perhaps it's much more simple than we have been thinking. Actually, I think that we don't have so many mechanisms in our bodily mind to produce different kind of things and version, and that way psychotic ideas is very much the same as many other affects that we are dealing. We know that some affect at some point of time they take over, and then we have this person have a diagnosis of anxiety, or this person has a diagnosis of depression, and the very same way we all may have hallucination, but we are not psychotic. But at some point when this take over, we can have a diagnosis. Now it's a question of psychosis. In one way to take into account this full idea of seeing us as full human being in our interactional context is the way that I've been involved to be in developing this open dialogue approach. I know that there are also other ways to do it. In Finland, we are very lucky because in Finland there is a long tradition of interest of psychotherapy of schizophrenia, and especially important has been the work of our professor in psychiatry Yrjö Alanen, who with his team generated an idea that they called need-adapted approach in psychosis, starting to have a individual psychotherapy, then realizing that families need to be included, and step by step came into the idea that there has to be integration of the different treatment methods for the best, based on the unique needs of every client. This idea is very different compared to the modern idea of evidence-based medicine that says that after you know diagnosis, you know the treatment. And this is actually in many ways opposite. You do not know, you only know the needs of the clients if you have a way to understand their life. And for this, to making this possible, they generated an innovation that they named as therapy meeting or treatment meeting, having an open meeting in which our clients are included from the very beginning, giving up the idea that professionals come together and make a plan for the treatment after we know the diagnosis, after we know after the admission interview of the doctor and after the testing of psychologists and so on. And now the idea was that we need to be in concrete relationship with him and his family to know what are the needs for them, in which way we could help with them in the best possible way. First, the idea was integrated in the psychodynamic individual psychotherapy and systemic family therapy, but step by step, of course, it has been opened up to think about the integration of all the possible ideas of the ideas. When I was a part of the team in Lapland, we had a supervisor, Jukka Aaltonen. Jukka Aaltonen is a student of Yrjö Alanen. And we all had an interest to generate family-centered psychiatric system for the people who had been hospitalized. We had a lot of interest of my first education, for instance, was not properly training, but I was very interested in psychodynamic psychotherapy for individual psychotherapy for the people who had psychotic problems. We tried to apply systemic family therapy in the hospital and realizing that this don't work. This is not the case to have families involved. And then 1984, we had at that time we every summer had something that we call schizophrenia summer schools. And we heard about the work of this Turku team, and they presented the idea of this open meeting, and it really was a big bang. This is it what we need. It really was a big because the day after we came to work, we changed everything. It's a bit funny idea. It's 27th of August 1984. It was the first Monday after the week that we have been, and then we decided that we change everything. It's a funny in this way because people ask that how long time did it take a change? 1 day. This is actually my proposal to all of you. Do not make committees, do not plan, do it. At the same way as Jorge did in Barcelona, and now we are in contact, and I know that it's working well. And in the doing, you meet with challenges which you need to solve in some way, and in solving those challenges, you may find the best way. So we were lucky because we got first experiences were good ones. Of course, if they would have not been good ones, perhaps we had stopped and realized that this is not. But at the same time, step by step, we also started to have experiences which were very confusing. Confusing in a way that we did not realize that when we opened the door for the patient to be sitting with us from the very beginning. The idea of this open meeting is that it's really start without any pre-planning, any meeting with staff, and everyone are there from the very beginning. At the same time, we gave up the idea that families are needed to be invited because of some problems in the family, indication for family therapy, but families were always invited into the meetings. And they had a lot to say. They did not at all accept the idea that they are targets of our family therapeutic intervention, but they had a lot to say how they want their daughter to be treated and met. And in that way, those confusing experiences came out of the fact that we lost the control of the treatment. There was a strong emphasis that we need to have a treatment planning. We need to know what is the first problem, what is the second problem, what is the third problem, what is the first method, what is the second method, what is the third method. But in this open meeting, actually everything was every time open. Every meeting actually creates a new plan for the future. And it was in conflict with the idea that we thought that we have to follow this exact plan that we do in advance. And step by step we came into many confusing conclusions. For instance, there were many impasse situations in the treatment. And in those impasse situations we tried to repeat the idea that we thought that this is the best for the patient. And in the end what happens was that we have to give up. We changed. And after that change started to happen in the patient, in our relationship with the family. And this was catastrophical conclusion. Because everything in our training, education is that it's the patient, they have to be changed. Their symptoms has to be get rid of. The families, I got the training in family therapy early 80s, the families has to be changed after the intervention that we made for them. And now all of a sudden we were realizing that it's us who are changing, and after our change something positive become possible. At that time we did not have any ideas of dialogues, but actually this is perhaps the most primary idea of dialogue on the whole. Because what happens in dialogue is that our gaze is shifted. From looking at our clients, we start to look at ourselves. And this is what is dialogue all about. I see myself, Mihail Bachtin says, I see myself in your eyes. I borrow your eyes to see myself. And this is what we do all the time. In the relationship with our clients, I'm all the time feeling, bodily feeling and seeing myself and thinking of myself. Actually, in a very concrete way, when I sit in the meetings with with the clients, I do not give meanings, I do not validate, for instance, their emotions. I don't, for someone who is starting to cry, I don't say that you seem to be very sad about it. But I can say that I feel very sad about it. I can speak of myself, and in that way be part of this dialogical response that we generate. These kind of confusing experiences led us to two conclusions. We need an education, and we started to have 3 years training for the entire staff. And actually it's also very important to realize that the study that we made, that I showed in the beginning of this, it's a study, it's a treatment that has been produced by a staff who may perhaps have the highest educational level of any staff that I know in psychiatry, because all have 3 years training in special training, not of course exactly all, because there is change, but this is the idea. So it's not only putting a work one idea, but has a very profound training for people who are in this idea. Second conclusion was that we need to have a research to understand what are these processes are all about, both of course the outcome, but step by step more and more about the dialogues in it. And I suppose that Western Lapland perhaps is the most studied psychiatric system in the world nowadays, because there is all the time ongoing research for 30 years, a bit more than 30 years time now. I know that there is a lot of criticism towards the studies that we have done in the academic field, but the criticism is most often very focusing on a very academic issue, and it don't have so much to do with what happens in real world. And for me, what is most important is the studies that happens in the real world, in the naturalistic designs, because the information that we get are most reliable, and in that way, I know that the research that we have done is the best possible that you need in psychiatry. One of the studies that we did was in the middle of 90s by Professor Jukka Aaltonen. We became interested after changing the practice some 5 years before, dissolving most part of the hospital beds and starting to organize mobile crisis intervention teams, going homes and taking that way the care of the problems. And then we had an interest, and Jukka especially had an interest to see what are the critical elements of this new practice and how are they different compared to the hospital-based system. And we analyzed patient records, actually from 2,500 patients, choose especially psychotic patients, and as a conclusion try to find out what are the optimal ingredients of an optimal treatment in a severe crisis. And in this conclusion is this qualitative content analysis, we came into the conclusion that the optimal treatment in this new system of care is one that guarantees immediate help, immediate having the first meeting within first day after the contact has been made. An optimal help is one that always takes into account the family, but also many times the other part of the social network, and that's why we named that as a social network perspective, not only family perspective, but also being open that there are many important situations in which we need to take care also the other part of the social network. And it's not only in the beginning to have an information, anamnestic information, but creating a kind of community, dialogical community about these persons who are part of the life of the patient or the client. And then we go on for as long time as needed. In the beginning, very intense meeting, and then step by step, not so intensive, but still having this social network there all the way through. In optimal care is the one that is flexible, finding the methods that best fit for the needs of the clients. Some need medication, some can manage without medication, some can take best advantages of individual psychotherapy. For someone, they work with occupational therapists, but someone need to be hospitalized because of suicidal threat for some days. So there is all the time a lot of this kind of ideas. A part of the flexibility is also the idea that we revise the system to not waiting clients to come into the clinics, into the hospital. These crisis teams go homes and meet with clients there where problems arise. Actually, this is an important idea because open dialogue as such is not any treatment method. It's a way of integrating the different methods that we use. But of course, very essential part that now we have a forum for this integration, this open meeting in which everyone participates and also can share about their experiences, what has happened in their treatments. Optimal system is one that is available for the clients and takes responsibility. This was very painful process to learn because we stopped and actually also denied the staff member to say no to the people who make contact. In our system, I suppose, I don't know, perhaps in Portugal also, the main response wherever you make call is that this actually do not belong to us. Please make a contact to the alcohol abuse clinic or other services. And we stopped this. We thought that whoever in whatever place is contacted is responsible for organizing the first meeting. And in the meeting we decide who are the best one to take care of this crisis. I was working with chronically ill patient. I didn't have anything to do with crisis intervention, but if some mother, for instance, had found my name somewhere and made a call to me describing her concern for her son, I knew that I'm responsible for organizing meeting even if I'm not a crisis worker. So I was listening her story, and she tells that my son has been also drinking quite a lot, and then I started thinking in the phone call, perhaps the problems of your son may have something to do with the drinking. So I don't say to her that please make a contact to alcohol abuse clinic, but what I say to her is that when I listen to you, I start to think that perhaps the problems of your son may also have something to do with too much drinking. Would it be okay to you that if we come to you tomorrow morning at 9, I invite someone from the A-clinic to come? And this is the idea of guaranteeing the psychological continuity across the boundaries in the treatment system. And of course, the most optimal way is that we could have integrated teams, that there may be social worker from the social office and nurse from the child psychiatric clinic and another nurse from the psychiatric clinic. And these people can form a team and take charge of the treatment process for as long time as needed. Also, if someone is hospitalized and perhaps in the hospital the patient has a very good relationship with one nurse and it's relevant that this nurse goes on as a part of the team afterwards, this is also possible, so that we all the time integrate the different memberships in the team. And then in the end to think that the idea of all of this is to increase the safety in the family to tolerate the situation that there is no ready-made responses and solution to be found. You need to tolerate the huge amount of uncertainty that is there. But this is a bit paradoxical, because in uncertainty, the resources are living. And the idea is, instead of aiming at rapid conclusions and interpretations, what this is all about, to make it a bit opposite. Open up all the time in a secure enough way to have place for the life to be there. And actually this also means that in crisis, we are not so willing to make an agreement that now we have to meet 5 times, but having a meeting, and in the meeting decide if we need second meeting, make an agreement of the next meeting, and in the next meeting we are open to think all the way through what are the next steps. And in this way, the idea of everything is to have a dialogue in the meeting, because these meetings are not for making a change, focusing on the symptoms of the patients or having a change in the family, but they are more for us to understand what has happened, and you could say in the way that it's written there, that these are for generating new words and new language for the experiences that did not yet have words, or had the words of psychotic behavior or anxiety or whatever symptoms there may appear. And if I think myself in that way, my position becomes a bit different. I am no longer the therapist who should know the intervention and exactly right comments and right ways to interaction, but I become a part with my team to this reunion, to this community in which we try to have new words in a very concrete way. In many times when I'm in the meeting, I repeat what people say. One young woman had experienced a separation of her. She was 20. A year before her parents separated, she thought that I'm a grown-up. My mom and dad can do whatever they want. It don't affect my life. But what happened was that she started to have different somatic complaints, went to one doctor or another, and no illnesses were found, but in the end this became almost a pre-psychotic occupation to her, and one doctor sent her to the psychiatric clinic. And there we were discussing about it, and she told this, and then she all of a sudden said that actually it was a bit sad when father moved apart. Without not having any other words, I repeated what he said. You said that actually it was a bit sad when father moved apart. She became silent. I said, yes. And then there is a short break. And I asked, could you tell some more about it? Could you help me understand some more about it? Because the idea of generating dialogue. And then there is a short break. And she realized that I can go on with reflecting what does this mean for my life. Only one short example about this idea. How to do it. About these meetings, some words. So the basic idea here is that we all the time work as a team. There's a doctor, there's a nurse, there's a psychologist, whoever are available. And actually one idea of this open dialogue that these teams are also, as we call, case-specific teams, because they are based, there may be some people working in the crisis team, but they always come together with, for instance, nurses in the local mental health clinic and so on. And every case has its own team that are there. But this working in a team, everything happens in these meetings in the teams is very relevant part. These meetings are not planned in advance. We expect to have a shared history, a joint history around this issue, which means that we come into the room by the same door opening, sit down and start to discuss. And this also means that we expect that the one who is most psychotic, most agitated or irritated is there with us. I hear a lot of saying in psychiatric hospitals that of course we want to meet with family, but we have to wait for as long time he become more coherent to be able to be in the meeting. And this is opposite. Meet when you are most psychotic, most agitated. In the meetings people usually become, in 9 cases of 10 they become more coherent. And of course for me this is much more constructive, because now the process of becoming coherent happens in relation instead of happening in isolation. And of course this is also a part of the life of the people they are living. Everything happens in the meeting. All the discussions among professionals of the different methods of treatment that we need to use. It seems that the most challenging part is the discussion of medication, but learning to speak about the different variation of medication is an important part. And when I've done a lot of interviews by families who have experience of this, they repeatedly say that it's so good to hear the professionals in person to speak of these ideas. They may be concerned if there is enough discussion among professionals in the way that the nurse was heard, because she knows best our son, and so on. So that it's a very empowering experience for the clients to hear this open reflection about the different ideas that we need to use to help these people. This means that neither after the meeting we come together to make a kind of conclusion, what should we take out of this meeting. These meetings can be, in a way, facilitated by a team. I'm most fond of the idea that there is a team that facilitates, everyone in the team can make questions, and I need to be familiar with my colleagues also in that way. But many people have also said that it's a bit too chaotic because I'm used to have more structure. Okay, then you can decide that one is interviewing and the rest of the team is more in a listening position. But in any case, there are four important questions about how to do it. This is open dialogue, so there is no ready-made structure that you need to do it. But the structure is constructed differently in any case. But four questions. How do you open up the meeting? How do you make space for all the voices becoming heard? How do you make space for professional discussion with each other, and how do you close the meeting? First, and perhaps the most important idea, is to open up the meeting with open-ended questions. How are you? Who would be best to start? How would you like to use the meeting? All are questions that allows to our clients to start to discuss about the issues that are most relevant for them at the moment. Do never open the meeting with your agenda. Do never open the meeting with your agenda. In many countries, I do not know if this is the case in Portugal, but in many countries now there is a very high idea that you have to do risk assessment before you go into the treatment. In the United States, they say that they have to fill a 7-page formula before they go into the treatment. It's a very dangerous issue for the clients in crisis, because it may be that one who has psychotic problems speak about them during the 5 first minutes, and if he's not listened to, he never after speaks about it. I've done research about it. It's a very dramatic case. Have your agenda in the end of the meeting, never in the beginning. Be sure that your clients can start to speak what they are up to. And in that way you also have motivation for them to go on in the painful issues. The one who usually starts to speak of most important issue, you realize that immediately. But then I have this second point also very important, and it is that to guarantee all the voices becoming heard. And for instance, people who come into the meeting in a crisis, it may be first time in their lives, and they are scared to death. And when they are scared to death, they are closed, bodily closed. And if I'm bodily closed, I'm not open to other myself, or I'm not open to listen to other. And that's why it's so important that we say that to the mother who is speaking, the thing that you say seems to be very relevant to go on. But before doing that, I would very much like to hear what's on your heart when you came here. And then we have a round to have words of everyone. And the father who is sitting there very close says that I don't have anything specially, so I'm open to speak. Everyone becomes a bit more relaxed, encouraged to utter himself, and also start to listen to them. The idea of this round is not to have a list of agenda that these are the issues that we have to handle, but is to have everyone to become part of this dialogical space or dialogical community. Very important detail in this. The third point is the idea of professional discussion with each other, which includes 2 parts. One part is all the issues related to the treatment that we need to do. For instance, if there is a need to come in to think about non-voluntary treatment decisions, make it open, look at different variations, and avoid a situation that it's only done by the decision by the doctor and everyone else nodding his or her head. But have a dialogue about these issues among the professionals. Second part of this professional discussion is something that we call reflective talks, in which we reflect about my feeling. How do I feel after listening the stories of the clients, and I speak to my colleague. I'm very, very, very careful that I speak to my colleague and not look at the families, because in that conversation they have place for the inner thoughts, inner dialogues when they listen what we have been thinking about. And every time after, end this by asking them, I wonder what were your thoughts when you were listening to us. In that way we guarantee that we do not make wrong conclusions and they can correct, no, that was not the thing that I meant. I have an experience that professionals discuss all too little with each other in the meeting. We are all too shy and restricted with this, and families really like about most time. Of course there are situations in which they do not like, and it's not idea to force up to it, but doing in the way. Okay, more or less into the end. Thinking about this, everything that the question that how come these results in this open dialogue system seem to be so different, especially in the most severe mental health crises, as in depression. We also have one study concerning major depression. And we do not, because the studies are descriptive ones, naturalistic, we do not have a control for finding causal explanations, but a kind of hypothesis. I think that there may be these four things that happens at the same time that make it possible. First of all, meeting people is in crisis extremely productive, because in crisis there is a lot of emotions and not so much rational thinking, and this implicit way of being in life is a very good point of having access of topics and feelings and issues that never before have been spoken about. And Ian Falloon was a professor in psychiatry in Scotland who used to say that the window is open to psychotic world within the first day after the contact. And that's so true. In a crisis, it's a very short, everything is in a contact that people made in crisis, everything is open. It's a very paradoxical, because you are in a dead end, you do not know what to do, and then you make contact, and all of a sudden everything is open. There's only question, what's wrong with my son? What has happened here? And this everything is open, it's very short, 1 or 2 days. But during that time, you have access of issues that were not possible to speak before are not possible to speak 3 days after. And it's not so much that we go into topics only to make them up, speak and continue to speak. But of course it's not enough. You need to have those dearest of your life, most important persons in your life, and perhaps with whom you also have conflicts there, to have the family, to have the social network there, and to have the have the conversations, and to have the polyphony of life there, of all the things, all the issues, all the persons who are there. And the third point is the idea of dialogue. I think that this is so good fit here, because in dialogue, when we come to have a dialogue here, we are not interested to choose what is the right topic, what is the right issue, what is the right opinion, but everything is encouraged to bring up. And in dialogue, the main idea really is that I start to respect. In our last book that we wrote with Tom Erik Angel, we have a motto: the way to dialogue is respecting the other without conditions. And this is a very powerful feeling, that you are respected in the presence of the family. Not a long time ago, I was working with a family that was in a very extreme situation. The son was hospitalized. He was at that time 33 years of age. And he called from the hospital and said that yesterday we had a terrible meeting here in the hospital with my family. I want to have a new kind of meeting. He had heard about this dialogical approach. They were living in different parts of Finland. Could they come to meet? I was working in the psychotherapy clinic in the university. Yes, of course. He said that my parents cannot sit in the same room, they are separated, but they have promised that for helping me, they are willing to come into the meeting. Then we prepared that we had a first meeting with him and her sister, that was 4 years younger, and the mother. He and her sister had not been so much to do. Most of the things that they discussed were a surprise to them. I didn't know that you think in this way. Then we had a second meeting with the two sisters and the father, and just the third meeting so that everyone came into the meeting. But it was, you could sense the feeling when they came into the room. They were walking like this. And then the little sister, she sat down and was looking into the floor and said that I'm scared to death. This meeting should have been 20 years ago, when the parents separated for the first time. After a while in the meeting, the mother said the same. This meeting should have been 20 years ago, when they separated. And there is a lot of very critical points, especially from the side of the daughter to the behavior of the father. And of course, at some point I became very, very concerned about the father and asked him, how is this for you? And he said, this is painful. I did not want to harm my children, but can we go on? Yes, we have to go on, he said. And in the end of the meeting, they said that this is so strange. In the meeting that we had in the hospital, they only had an interest how mad I am. All the questions were aiming how mad I am, how disturbed our family are. But in this meeting here, we all feel that we have been listened to and respected to, even if our life is a hell, as they said. Even if they are in this 20-year conflict with each other. And actually we met together 1.5 years, and in every meeting they repeated the same. This is so strange, feeling that we are respected. And I think that this is a very good illustration of the dialogical practice. We are not here for doing so much, but we are really making place for the voices becoming heard. And when this happens, there is a new resources in the life as for this family, which was very different in the end when compared to how they were in the beginning. And then the fourth point is that if we can have, by this way doing, what happens that we really can decline the role of medication, and in that way we also can prevent the harmful effects of the medication. I think that this is very important part of the practice. Be encouraged to rethink what is the role of medication, and especially take distance from the automatic medication and all the way through to think about the importance. Well, if I think of my more than 40 years in this field, and as a young clinical psychologist, I was very occupied of different theories and methods, and I thought that if I only read and learn and do all those things, I can do very good for the clients. I think I could and we can do. But it was very much focusing on the methods and techniques and intervention. But now in this dialogical way, we start to look at ourselves more, and I think that it's a much more basic values of human life that are there to be taken into account. And of course, there is no more basic value in human life than love. And this is what the family members so often say after the crisis. It was so painful, but I learned to love my son, with whom I did not have a relationship for 8 years. And so beautiful citation for David Peterson, who is a literature researcher, and he said that there is no dialogical relationship without love, just as there is no love in isolation. Love is dialogic. Thank you.